Thank you so much, Jeff. So, Scott has already alluded to the Global Spine Care Initiative. And what I have done is that I will present to you the recommendations when we went through all the scientifically admissible guidelines that we are now published in the European Spine Journal. So if you look at this, the training and clinical evaluation, we have learned that it's extremely important to be well aware and to be confident in the clinical examination, and then to be able to order additional diagnostics if necessary. The assessment and diagnostic studies, we are looking at we're better as clinicians as ruling out condition than we are at ruling in conditions. The red flags are accepted worldwide, we can say. The yellow flags are really important to look at the prognostic and the prevention of disability. And the most of the diagnostic studies actually come from the high-income countries. We have much fewer diagnostic studies in low-income countries, but we have fewer diagnostic studies overall. We also believe strongly that over-treatment or over-diagnostics can lead to that disability, as well as under-diagnosis can lead to disability. So the training and the knowledge in diagnostic is important. So here is one of the papers, and this comes from the Global Spine Care Initiative, and we were about 22 people who came together to look through the diagnostic guidelines. And the key points, which is very nice, that they really give you through the Eurospine, is really that patient with spine-related complaints includes ruling in or out the disease and the decision to make further diagnosis if that's needed. And the next point is the advancement of patients by the clinical diagnostics. So we have really good recommendation today, and what did we do? Well, we sifted through about 3,069 papers. We took away, you can, probably it's hard to read on the left-hand side, but we sifted through all these papers. We took away all the duplicates, the ones that were non-eligible and with no, the one paper that has no methods, the ones that were irrelevant, and the few, there was only three that we couldn't find, as we had a librarian on the team also. Out of this, we then also set up the criteria for selection for inclusion and exclusion. We set up a critical appraisal by 2 people. This is pretty standard today when you look at systematic reviews and the large reviews that are well done. We resolved a disagreement between the 2 reviewers by discussion, by a 3rd reviewer, or by contacting the authors. We rated all the papers with Agreed 2, which is a formal system to rate guidelines. We synthesized the findings, we formulated the recommendation, we wrote the paper, and European Spine Journal, when they received it the first time, thought that we should update one more time our literature review. And that's why you have reviewers, and good reviewers, who tells you, listen, this took a while to review, but now you need to update it. And we did that. So what you can see here is these are the guidelines that were accepted. It was the American College of Occupational and Environmental Medicine, 2 of them. American College of Radiology, 2 of them. Chow et al. From US, 2011. Chung, 2011, the same group, pain medicine in the United States. Manchikanti from 2013, North American Spine Society 2014, and the work loss data, 2 guidelines from 2013, both of them. What is interesting here is, if you can see, all guidelines doesn't take into all into account. So you have a big, here you can see that there are many guidelines who do not mention certain diagnostics. So there are less, as I said before, in terms of diagnostic than it is in terms of treatment. So our recommendation here, the recommendation one, is that clinicians should always take clinical history during the initial assessment of patients with spine-related complaints. The history should aim to determine the presence and signs of symptoms suggesting serious pathology, the red flags, and psychological prognostic factors, yellow flags. And what you can see over the last 10 years, it's really the red flags are now complemented by the yellow flags, and the yellow flag starts to be routine questions as the red flags is accepted all over the world. And this is for our 13 low-risk of bias guidelines. They all recommend this strongly. However, they don't tell you how to do it, right? So the serious pathology is, of course, this. You've heard this before. And if we go through this, what do you need to know in terms of the trauma? You need to look for history of direct trauma, any evidence of neurological pain, chronic slow pain, and increasing at night. And we can go down this, and if you look at the next, for cancer, for example, you have history of cancer, you have insidious onset, you have unexplained weight loss, you have no relief at bedtime when supine, failure to improve during 1 month, age more than 50 years, male with osteoporosis or compression fractures. If we go to spinal column infection, then we see that it's more common in this part of the world. You have to look for fever, you have to look for night pain. I don't know why the text is not coming up, but let's see if we can get it. Here we go. Increased drug use, previous surgery, no relief at bedtime when supine. If you go at Cardiac syndrome, for it, something is wrong. Help, please. Okay, anyway, the 3 bubbles, as you can see there, tells you about the nerve compression disorder, the spinal disorders, and the myelopathy, which is actually sometimes missed, and that's pain and stiffness in the neck, heavy feelings in the neck, inability to work at the brisk pain, deterioration in the fine motor skill, fumbling, not able to write your name, intermittent shooting pains into the arms and legs, like electrical shock when bending forward. And you will have demonstration by Jeff and Adam and Stefan about the clinical in the smaller group, I believe, tomorrow. And these are kind of, in a nutshell, the red flags and the questions or the items that you have to look at. I apologize that it went a little fast there, but you will have that on the video later. So what about the clinical history and the screening questions? We have, in this article, we have suggested that, for example, pain and numbness and weakness, stiffness. When did your symptoms, where are your symptoms located? Are your symptoms constant or intermittent? How do these symptoms limit you? How much does the pain interfere with your day-to-day activities? Can you work around the home? Can you participate in social activity? Will this affect your household chores? And when did the limitation begin? How long have you had this activity limitation? Has this happened to you before, or had this previously being treated for this same condition? We also set up in this article, we set up for the yellow flags, and you can see here, this has to do and to deal with all the conditions that are modifiable. And who things. These are, for example, stress, these are depression, these are coping, these are catastrophizing, these are expectations, and all these are modifiable and treatable conditions if you ask the right question. How stressed are you by your condition, for example? Can you cope at home? Do you lately feel that everything is difficult? Do you feel depressed? Now we have very few articles or papers, or you can say study, who deals with the perception of catastrophizing, anxiety and stress. And we believe today, when we go through the few papers, that the expression of telling us as clinicians may be different, because most of these papers are from the high-income community in the industrialized countries and summarized in this statement. This may very well, this is what it looks like today with what we know in 2017 and 18, but this may change when we get more information from low and middle income countries. And we hope it's coming because it's important so we can ask the right question in the patient-centered care that we would like to give. So recommendation 2, clinicians should always perform a physical examination for the musculoskeletal and neurological system. And Worshman Care has a toolkit with recommendation for basic clinical examination of the spine. Demonstration will be done at this conference. And we need to only use clinical examination tests with high validity. And there is a lack. Today, you can say the clinical examination for radiculopathy are pretty strong. They have high specificity and sensitivity. But if you compare with palpation, it's actually not so good when it comes to specificity and sensitivity. Recommendation 3 in this paper for non-specific low back pain. Clinicians should not routinely obtain diagnostic imaging in the initial assessment for non-specific low back pain. And this was recommended by 8 of 13 estimated guidelines. And the reason for this is, of course, to reduce the radiation exposure, reduce the cost, but also reduce the medicalization. Because we have seen from several papers that first the awareness of physiologically degenerative changes as diagnosed by immediate imaging may foster fear avoidance beliefs with the patient in some patients and become an obstacle to recovery. So if you find no need, and Alberto Zerbi will talk about this, to get an X-ray in the beginning, because you can find no symptomatology or signs, then there is no need for an X-ray with the patient coming in with non-specific low back pain. Second, in this exposure to radiation doses in computed tomography or radiography is also an issue. And third, various epidemiological studies have shown that it is rare to find serious underlying condition in primary patients with low back pain that comes in for the first time. It is around 3 to 4.5%, depending on which country you look at. It may be a bit higher in low and middle income countries, and we have to be aware of that, as there is more infectious diseases such as TB, or perhaps a fracture of a collision or something like that. Recommendation 4 is that clinicians should perform diagnostic imaging when signs or symptoms suggesting serious pathology is suspected, because you need to clear that there is no serious pathology in the spine, right? So the red flag, if you want to be sure that there is no red flag, then there is a need of an imaging. And then, of course, when the patient if the patient needs to go to secondary or tertiary care for surgery or other treatment, then there may be a need for further imaging. Recommendation 5, clinicians should not routinely perform electromyography and nerve conduction studies for diagnosis of intervertebral disc diseases with radiculopathy. And the reason for that is that the studies that has been done is not really showing high validity. However, if there are selected patient who needs that, because the specialist or the surgeon say we need to do an EMG or evoke potential or whatever during surgery, that's a different issue. But in the primary care, this is not recommended. Recommendation 6, clinicians should not send or perform discography for the assessment of spinal pain, and this is based on the latest paper, among other, the one from Karaji in the United States, that has seen some complication arising. Now, the debate about discography is really very high still among the surgeons. You have one school who still believes in it and another school who don't. But for the primary care, there is no need to really send for discography. This should be done later on by the secondary or tertiary level of spine care. So these are the tests that we could not find any evidence, or there was insufficient evidence, like the cuff impulse test, the belt test, hyperextension test, femoral nerve test, slump test, and palpation for spondylolisthesis, very low validity. Imaging, X-ray, and scanner, you can see there is a whole host. When somebody come in with primary care back pain, that there was we could not find any studies, diagnostic studies, to really substantiate these imaging tests that Dr. Zerbi will talk about later, also at least a few of them. So the last one then is really the recommendation that you will see in this paper in the Eurospine Journal also. These slides are actually available through the Eurospine Journal. It is really the emphasis on the clinical evaluation, on imaging, and you can see there is about 6 recommendations here also with the ones that I have gone through. So most of these guidelines were strong guidelines. They reached at least 6 out of 7 points, 5 to 6 out of 7 points. And by summarizing all these guidelines, we have now been able to identify the gaps where we need to fill in with more research for the clinicians. And we can also say what are the tests, diagnostic tests, imaging tests, clinical examination tests with low validity that we probably shouldn't use too much. Many of you may be skeptical to that, and if you have any question and you have scanned this literature, I must say this was one of the more pleasant literature review we were doing, because we saw that many of the guidelines came together. Thank you so much.